This podcast is produced by Compass Coaching Limited. Compass Coaching, there when you're facing the questions and course corrections of life, helping people like you find their true north. Now, on to the fun bits. Hey everyone, I'm so glad you plugged into my podcast today because today's subject is pelvic organ prolapse, or POP. This is a topic on the sensitive side and not ideal for little ears, but concerns many women worldwide and is not a regularly scheduled programming topic of discussion. Pelvic organ prolapse, simply put, is when one or more of the organs in the pelvis slip down from their normal position and bulge into the vagina. It can be the uterus or the bowel, the bladder, or the top of the vagina. A prolapse isn't always life-threatening, but it can cause extreme pain and discomfort, strain on relationships, embarrassment, confusion, and more. But most women don't talk about it. Many don't even know anything about it. So that's why it's important to discuss. And that's just what we're going to do. Sherrie Palm is my guest today, and whether written or expressed by articulated word, advocate, or activist engagement, Sherrie mobilizes patient, healthcare, academic, research, industry, and policy sectors, providing the conduit to engender vaginal and intimate health evolution. That's a mouthful. Sherrie is the founder and CEO of the Association for Pelvic Organ Prolapse Support, or APOPS. She is a key opinion leader on the subject, a vaginal and intimate health activist, author of the award-winning book, Pelvic Organ Prolapse, The Silent Epidemic, a total page-turner, and I'm not even kidding, and an international speaker regarding women's health empowerment and multiple aspects of pelvic organ prolapse quality of life impact. Sherrie's journey began in December 2007, post-diagnosis of her own pelvic organ prolapse, which we'll get to talk about in just a moment. But upon returning home and researching POP, she discovered how common the condition is, that it's been medically documented for nearly 4,000 years, and stigma continues to shroud this condition in silence. Well, as in an effort to increase awareness, Sherrie published her first edition in 2009 of The Silent Epidemic, and in 2010 founded her nonprofit to enhance even more awareness. And APOPS was born. With grassroots energy, APOPS bridges women and physicians, academics, researchers, industry, and policymakers in 177 countries. That's a lot of bandwidth. Expanding global awareness and evolution of pelvic organ prolapse directives. She's currently working on her fourth book that will be coming out in the press this September of 2022, and I am honored to have her on my podcast today. Welcome, Sherrie, and thank you for shedding light on such an important topic, especially today, May 31st, as we are on the tipping point of June 1st, which kicks off Pelvic Organ Prolapse Awareness Month. Who knew? So will you share a little bit about your own story and enlightenment on this subject, and then we'll get to some hot seat questions.
Sounds awesome, Miriam. First and foremost, thank you so much for this opportunity to share our information with your audience. It's pivotal that we get this information out to all women, the shroud that encases this topic is massive. So my own journey began, as you mentioned, with my diagnosis in 2007. But prior to that, just skipping backwards a little ways, I had been diagnosed with MS at 30 and was wheelchair bound, short time frame. So I was extremely proactive to everything I could possibly do to avoid the wheelchair. I became very aware of sensations in my body, of reactions to situations, etc., and learned how to basically fix myself. I mean, I still have MS, obviously, but it's very, very controlled. I never hit a wheelchair. So
you were kind of on high alert already about
exactly
what was going on in your body and recognizing things. Okay, got it.
Exactly. So a little bit more fine-tuned than the average person, probably, to different symptoms. So fast forward to 2007, let me say that at that point in time, my best friend was my healthcare practitioner, and we would go out and we would have lunches or dinners or whatever. We talked medical all the time. And so when I started to notice symptoms that I didn't understand, and they went on for several months, I would notice a bulge, some kind of a bulge of tissue when I would wipe after I would urinate. I've always worked a 60-hour week. So I had to go, I'd run to the bathroom, I'd pee quick, drop trowel, pee quick, pull the pants, pull the pants back up. But I noticed that there was something there. And after about 3 months of noticing that sensation, or not sensation, but that bulge, I got curious, what is that? And I got a handheld mirror out and tucked it down below when I was standing up after I went to the bathroom. And I saw a walnut-sized lump coming out of my vagina. And I thought to myself, that can't be good. So you flash initially to tumors, of course, when you see a lump like that, especially one that size.
Kind of unnerving.
It was a little bit, but I wasn't really freaked out radically because I never heard of vaginal cancer, which there actually is vaginal cancer, but I never heard anything about that. So I wasn't hugely freaked out. And I sent an email to my buddy, the doctor, and said, something's going on here. And when I think about this, she said, come on in, we'll do a pelvic examination. And so I shot over to her office that afternoon and she did the examination, and she had been doing my pelvic examinations prior to that. So she was familiar with my anatomy, and did the examination and said, you have pelvic organ prolapse. I'll fit you with a pessary. And then if you don't like the pessary, I'll refer you to a really good urogynecologist, and you can have further evaluation and consider whether you want surgery or not. I had no clue what she was talking about. And after having been through the MS stuff, I was extremely proactive about all aspects of my health. My female health, I was very, very engaged with that stuff. So to be told you have this condition that I'd never heard of, first of all, was kind of like, what up? What is that?
Mm-hmm.
And then she's mentioning pessary and urogynecologist, and I didn't know any of those terms. So I went home and did what most people would do. I got out Dr. Google and started digging to see what I could find out, and discovered in short order that this condition is extremely common. At that point in time, the stat used was 3.3 million women in the US. I couldn't find a global stat. And now they're saying 50% of women. So wow. It's definitely moved forward. So when I saw the number, 3.3 million women, I was enraged. I was livid. I could not believe that a condition existed that was so incredibly common, and I'd never heard of it when I'd been so proactive with digging into the health stuff. Mm-hmm. And it wasn't just for myself. I dug into health issues for other family members as well. So I just thought that was really weird. So I just kept reading, and I'd go down to the library, spend a day down there digging, and after quite a bit of time in that rabbit hole, that first week, it got into the second week, and then I just knew, and I don't know how I knew, I just knew I had to do something about this, that this condition is so common, and I didn't know. Then if I don't know, and I've been so proactive about my own health, women don't know. And so I recognized I had to write a book about
how can it be? Yeah. How can it be so common? I'm sorry to cut you off there, but what you're saying is, if it's so common, how is it that so many women don't know? I mean, It's kind of a rhetorical question at this point, because we'll kind of get into that. But I just, I think that's a really important point.
Exactly.
So
that's how I felt. That's how I felt. Right? Mm-hmm. Because I was livid, and some women, they're more upset, but I was just ticked off. I was furious. So after a couple of weeks, then I recognized, well, I have to get this information into the hands of women. Women need to know this stuff. And so I'll write a book. I don't know what made me think I could write a book. That's crazy. I don't know anything about writing books, So,
wow.
But I felt so upset, so angry that I thought, well, that's a way to start something going here. And of course, like most first-time authors, I thought, well, we'll get this book written and I'll get it in the hands of women, and then they'll all learn about this condition and everything will get better and it'll all change. All these illusions that you have as a first-time author. So she fitted me with a pessary, my doctor did, and it worked great. And some women have difficulty getting a pessary that fits correctly. And I didn't. With me, she right out of the chute, she got the right size. So I went home with the pessary, and I learned, I Googled that too.
I'm just going to ask you a quick question. I just want to, we might talk about some other preventative care, but can you just explain to our listeners what a pessary is?
Sure. You bet. So the term pessary was not familiar to me at all. So digging down into it, and I know a lot more now than I did with my digging back then, but it's kind of a diaphragm looking device. And there's 20 some different types of pessaries, or probably even more than that now. Different shapes and different sizes, because we're all shaped differently on the inside, just like we are on the outside.
Sure. Sure.
So what they do is they like with a diaphragm, what you do is like a ring-shaped device. Sometimes there's stuff in the middle of like a sheet in the middle, and sometimes it's just a ring. And you can fold it in half and you insert it. And back in the day, that was used as a form of contraception. So pessary is kind of the same looking kind of thing, where it's a device that some of them you can fold in half, insert them, and then they open back up inside of you. And that creates support for your organs above that bony structure there. And some of them, your doctors have to insert for you because they're different, they're odd shaped. There's support pessaries and there's space filling pessaries, two different kinds. And the space filling ones are different shapes depending on which organs are prolapsing, what symptoms you have, etc.
So this is definitely something that you would want to discuss with your doctor as far as different options that are non-surgical based kind of thing. Okay. I just wanted to give a little bit of an overview of what a pessary was, because I didn't know when we started out. I actually learned about a pessary in your book. So anyway, okay. So you write the book, you're in the process of writing the book. Who am I to write this book?
Right, exactly. So I was happy with the pessary, but I work a 60-hour week. I've always worked a 60-hour week. And so, you get up in the morning and you let the dogs out to pee and you go pee yourself. And then you let the dogs back in, and I would exercise and hit the internet real quick to check on my email. And then I would go eat breakfast, and then I would jump in the shower and do the face and the makeup and all that stuff, and then get on with my work day. Now I have to add inserting a pessary to all of that.
Right.
And it was like one more thing to do. And I thought, this is crazy. I don't want to do this for the rest of my life. It worked great. Mine worked great. I was lucky. All women don't have that great luck, but I did. But it was just one more thing to do. So I contacted my buddy and she says, okay, well, I referred you to this urogynecologist. She's wonderful. You're going to love her. And so I went to set an appointment set up to go see her. And then she was the one, your primary care practitioner will tell you have prolapse, but they can't usually tell you what types of prolapse. There are 5 types, and they can't usually tell you what degree of severity you are. Mm-hmm. That's what a urogynecologist does, and that's a subspecialist in gynecology. That's like the next tier up. They have an additional 2 to 3 years of medical school beyond gynecology school.
Got it. Okay.
So I went to see the urogynecologist, and she was wonderful. I just adore her. She's an amazing urogynecologist. And she did the examination. There's 4 grades of severity with prolapse, 4 being the most severe. I was grade 3 severity. I had 3 types of the 5 types. And that's quite common to have 2 or 3 types, not just one. So I had a cystal seal, which is bladder. I had a rectal seal, which is the rectum. And I had an enteral seal, which is your intestines. So she says, okay, she says, here's the plan. She says, why don't you go home? This was I was diagnosed in December 2007. And then I saw the urogyne in January of 2008. And she says, go home. We've got spring coming up and then summer. Take your time with this and just kind of flow with it, get to know your body. And then go out and, play in your flower beds, blah, blah, blah. Come back and see me in the fall. And then we'll talk about surgery more thoroughly.
Okay.
I was like, tooties. Wrong answer. I want surgery yesterday. I don't have time to deal with this.
Right.
And that's pretty much my personality too. It's just like, just fix it. Just fix it.
Right.
So she's okay. Well, if that's the way you feel, we'll get you scheduled for surgery in February. So that's what we did. So I used the time between my diagnosis and my surgery to gather all my research for that first book. And then I used my heel curve, which was a 12-week heel curve. This is major surgery. I used that heel curve to write the book. And then after I got it written, then I had to chase down a publisher. Back then, self-publishing it barely existed,
right.
It was whisper at that point. Uh-huh. So I just chased down a publisher. And of course, any author will tell you that it's reject. Right. So you just keep looking and looking for a publisher that'll grab your book. And then I finally found one, and I was elated. And each of these steps with writing a book, there's a lot of steps you go through that people don't realize. And it was all a learning curve for me because I'd never written a book before. So each step took time to research, how do I do this now? And how do I do this now?
Right. It's a total process to get it produced. So you did eventually get the book published. So you're writing this while you're healing. Mm-hmm. And so you get the book published. This is your first edition. And that was 2009.
Right. Right.
And so then how did APOPS kind of come about then? That was kind of on the heels of that?
I was about 15 months into marketing that first edition when the light bulb came on. If I wanted to reach women effectively, if I wanted to nurture and guide them effectively, I should found a nonprofit. And I knew nothing about the legitimacy of nonprofits. I knew nothing about the difference between just saying I have a nonprofit and having a 501c3, which is a federally recognized nonprofit. And so I had to learn about that. In the process, I was also building the website and trying to—
a lot of other details that went into,
in place for
exactly. And I just want to say, we're going to get this also at the end, but pelvic organ prolapse supporting.org, y'all. If you're looking for support, pelvic organ prolapse support.org. That's where Sherrie's website is about APOPS. There is a lot of information on there, but okay. So you've gone through this process. You've already had a little bit of history already with the MS. You're sensitive to your body. You are sensitive to what's going on in your body. You go and you seek help. You're super proactive. You do not lean on your laurels. You're like, I'm having this now. So you get the surgery, then you're, not just relaxing and, sitting back and drinking some champagne while you're healing. You're like, I'm going to write a book about this, that really has never been done in this way, shape, or form. And then I'm going to, start this nonprofit. You seem to accomplish a lot at all times. I'm very impressed. And I'm so glad that you have, because this is an important subject. So getting into kind of doing a little bit deeper dive into prolapse, why does this happen? It's not, you said something earlier before about your own experience. Even though your body, you can't control your MS, you can't control, there's certain things you just cannot control. And I know that a lot of people aren't talking about this because there's a lot of shame around it. There's a lot of guilt, and people think it might be their fault. They've done something. Really athletic women, this can happen to runners. There's a lot of other, genes can play a part in that. But can you just give us kind of a synopsis of why this can happen in a body?
Absolutely. Two of the most impactful life events that women experience, childbirth and menopause, are the two leading causal factors for pelvic organ prolapse.
Okay.
So that all by itself is a massive, massive causal sector. And with the childbirth, a very condensed version here. I mean, you have a large baby and you're smaller framed. You have a long second stage labor, and that baby's head is laying on the nerves in that vaginal canal, which causes damage down the road. Maybe not initially, but down the road. Forceps delivery, suction delivery, they're inserting tools into you that creates structural damage. So there's, just childbirth alone, there's a lot. That's a heavy, heavy hitter right there.
Yeah.
Menopause, when your estrogen levels drop. And so we're talking about even in your perimenopausal years, as your estrogen levels drop, your muscle tissue strength and integrity drops. Women don't equate estrogen with muscle strength. They think about testosterone. Estrogen is absolutely a precursor to muscle tissue integrity. And so as that estrogen level drops, the muscle strength drops, and those muscles in the pelvic floor are what's part of that support structure for those organs up there. So as that muscle gets weaker, and it's kind of like, instead of being a firm platform that those organs are sitting on, now it's like a wussy hammock. It's kind of sad.
Right.
So that's a big deal. But there's a lot of other secondary causal factors, and every woman's a little bit different, and every woman has different causal factors, and they're usually stacked. It's not usually one or two. There's one primary and then other that are kind of like stacked behind it. So
sure.
Think about heavy lifting. Well, when we think about heavy lifting alone, when you pick up something heavy, it pushes pressure down. So your organs are pushed down. So we think about things like, work related, you're at a job in a factory, you're lifting heavy boxes. We think about fitness people that are huge into lifting heavy weights, they're Olympians, whatever. But what do women do all day, every day that have young children? They're picking them up.
Right.
And they're not thinking to contract the pelvic floor to create some structure before they pick them up. They pick them up to put them in their high chair, they put them in the car, they put them in the bathtub, put them in the crib. And you're nurturing.
So they're literally lifting weights all the time.
Yes, exactly. All the time.
So it's compounded by the fact, and I think this is a really interesting point to make, is that there's some definite causes that create this, that can start the ball rolling, right? Mm-hmm. But there's all these other mitigating circumstances that play a part in it, like chronic constipation,
Right.
chronic coughing,
Right.
a hysterectomy.
Right.
Talk to me a little bit about those, because these are things in and of themselves. Somebody might cough because they have, bad lungs or emphysema. Like, I want to avoid people like freaking out also and thinking, oh, I'm coughing a lot. I had a cold or something and I'm going to have prolapse.
Right.
So talk to me a little bit around this.
Okay. So typically when we're looking at this through the primary and the secondary lens, you'll have a woman who's had, every time you have a baby, it increases your risk for having prolapse.
Okay.
So say a woman has had 3 babies and she gets a really hardcore flu where she's coughing, and it goes on for like 3 days. And it's like the repetitive, nonstop, hard jerking coughing. And she's just coughing her lungs out basically. So what's happening here is she already has a predisposition to weakness in the pelvic floor muscle structure. And now when she coughs, every time she coughs, she's jerking and jerking and jerking those organs downward. And that is making the damage that's already there worse. Mm-hmm. The same thing goes when we talk about chronic constipation. You may already have had your 3 children or whatever, and now you're chronically constipated because you have a rectal seal and you don't know anything about prolapse or rectal seals or anything like that. Mm-hmm. And you have to go. The urge is there. You have to poop. And you sit down and you're pushing to get that stool out and it's just not moving. Well, every time you're bearing down to have a bowel movement, you're pushing all your organs down. Right. Not just the stool inside that colon. So these sidebars, they all stack up. I had 7 causals between the primary and secondary. So everyone, again, is a little bit different. Every experience is a little bit different. There's other situations like I just have to throw Ehlers-Danlos out there too. So I know
sure.
That.
You bring up a really important point. I know that childbirth is one of the primary reasons, but talk to me a little bit about women who haven't had any kids. There are a lot of women that just aren't having kids, they're adopting, or they just choose to not have children, and they're still experiencing this as well. And I know there's a lot of other causals. You mentioned menopause. This is a big deal for many women in my life. And so can you talk around that a little bit more?
Okay, well, let's hit the menopause one first, because it is the second leading causal factor. So again, as those estrogen levels drop down, women are focusing on, their hot flashes, the night sweats, the foggy brain, those kinds of symptoms are the ones that get talked about all the time. Right. Atrophy or vaginal atrophy, dried tissues. And there's no thought given to the fact that as that estrogen level drops, it is making your muscles weaker. And I'm not just talking about pelvic floor muscles, it's muscles in your entire body. Your biceps are weaker. They look wussier and they're weaker, and your quads and your whole body, all of those muscles get weaker. So there's so much fear factor that was generated about estrogen supplementation, which is just really unfortunate, because estrogen is something that is vital to women's health balance. Vital, vital, vital. So we look at this. I mean, if you've had a baby, you've got this huge causal factor. That's the top one. And now a few decades later, you're going into menopause, maybe 2 decades later, you're going into menopause. And so here's the second whammy. That's a significant whammy. So these are 2 primary causals back to back.
So for women who've given birth, now you're just compounding it.
Exactly.
Right.
Exactly.
And so for women who've never given birth, now it could even be, this is the beginning of this atrophy in our pelvic floor. Okay.
Some of the other issues that occur. Mm-hmm. And so for the women that have not had children, most of them, not all of them, but most of them, the reason that they may have some issues, and besides the other, like the menopause and that type of stuff, Ehlers-Danlos syndrome is a very rarely recognized tissue integrity condition. There are some coexisting conditions with prolapse that predispose you, again, to prolapse issues. And Ehlers-Danlos is one of them. And this is where the structural tissue at the cellular level is weak. It's genetically weak. It's a genetic condition. And these are people that are double jointed and have really stretchy skin. And so these women, when they're toddlers, their mom's like, she's so good and she's so stretchy. I put her into tumbling, not knowing that this is Ehlers-Danlos syndrome. And there's 13 types. So it's very variable, which type and which symptoms you get from EDS.
So trail back. What are you calling that?
Ehlers with an E, Ehlers-Danlos syndrome. EDS is the acronym.
Okay.
And that's
just another, that's the term for double jointed.
And they don't refer to it as, because there really aren't two joints in your joint. That's
Right. Okay.
I don't even know.
Okay. I just think that's really interesting. Okay.
That's what people refer to it as, the
Okay.
people that can take their thumb and bend it back and touch their forearm with it, double joint, people that can put their shoulders completely behind their, I don't know how they do it, but that's just how their bodies are. So,
okay.
So they have a lot of problems with muscle tissue issues.
Right.
And it also impacts the heart, even in some of these women that have certain types of it. So the intersect between POP and EDS is significant. And I started to notice years and years ago that women were coming into our space that were double jointed with prolapse. And then I started to go a little bit further down the rabbit hole on that. And then I realized that there's a connection here. And that led to a whole separate pathway to explore, because their needs and their issues are distinctly different. These women have the most difficult time capturing success with surgery because their tissue is so weak. They're most likely to have surgical failure. They're more likely to have repeat surgery. And for them, the non-surgical treatments are very ineffective the majority of the time. So that's the hardest sector of women to try and guide because of what they have to deal with.
Right.
So I wrote a paper recently about this, and it was about, and they don't know for sure because women aren't screened for this and doctors don't know about EDS, just like POP. Between 10 and 15% of women have some form, one of the 13 forms of EDS. And so you may have one double joint or all double jointed,
right?
And extremely variable.
So this is definitely one of the things to be looking out for. Right. Can you talk to me a little bit about, I want to talk about the types and the symptoms. What are the types of prolapse?
Okay, there are 5 types.
Yep.
Distal seal is probably the most common. And that is when the bladder drops down. And so with that particular type, you're looking at incontinence type issues or urine retention usually. And it can be in the earlier stage. So there's 4 grades of severity. So in grades 1 and 2, you may be, the whole, and I hate to refer to it as a joke, but that's the way it's looked at. You leak when you cough, or you leak when you sneeze, or when you laugh.
Sure.
So we're looking at where that once in a while little tiny itty bitty bit of urine comes out is something to pay attention to. That's not a nothing. That's something to pay attention to. So then as time goes on and the prolapse continues to progress forward, well, now you're having more frequent leakage, or more easily the leakage comes out. And that's in your earlier stages grades 1 and 2 of prolapse. Then as you advance into grade 3 or grade 4, the harshest type of prolapse, you can't get the pee to come out. Now it's urine retention. And the reason that it won't come out is because the urethra, which is your escape tube for the urine to come out of the body, is crimped. So picture a water hose, and you just bend it in half and water stops coming out. Same thing with the urethra. So because those organs in the pelvic cavity, when one starts to shift, they all start to shift. It's like I look at it, visualize it as a wall of soft bricks, soft blocks. And so they're squishy, and then one starts to shift, and then they all start to squish, and they're in different positions. And so that impacts all of, one impacts another organ throughout that system. So that's the main stuff with the cystal seal. Rectal seal is your rectum, and that's the large colon. Mm-hmm. And so what happens with that, and basically not all, but the majority of the types of prolapse are like hernia related. So with the colon, what happens is a tissue herniates out the side of the colon, and the poop gets stuck in there, and it can't come the rest of the way down the canal. So it doesn't matter how much fiber. Women are told, they go to the doctors and they're like, I'm so constipated. And the doctor will say, well, go home and you got to get more exercise and drink a lot more water, but you got to kick up your fiber. You need a lot more fiber in there. So go home, eat a bunch of fiber, and that should take care of it. And it doesn't. And women typically, not women, people in general tend to think grain fiber when we think fiber rather than on the produce side. And that actually makes it worse with prolapse. So it turns into a chronic constipation situation where you're not just constipated once in a blue moon. It's every day. You want to poop. Lord knows you have to poop. The sensation is still there, but it won't come out.
Right.
And so women use different kinds, like Miralax is a pretty commonly known. My dogs.
That's Sherrie's dog, by the way.
My
Everybody.
dog making scratching sounds over here.
She's trying to upstage the conversation.
Yes, I'm not paying attention to her. Miralax is a product that's used that helps women with that, but even sometimes that doesn't work very well. When you have this rectal seal. So you're pretty much, it's just this is your constipation is your everyday companion until when and if you choose to have surgery. And even after surgery, it takes a while for things to level off because colon has muscle memory. Mm-hmm. And if you've been taking, some women, they resort to enemas because they're just so frustrated. They can't stand the sensation. And when that stool backs up, now you're all bloated and gassy too. Right. And you're just like a big block in your middle of your guts, So some women resort to enemas. Well, when you use enemas or you use over-the-counter products that are supposed to stimulate the colon to evacuate that stool, your colon gets used to it. And then it says, you know what, if you're not using that stuff, I'm not pooping at all. So sometimes women have to go through a period of time after surgery, even where they have to keep doing the right stuff. And then eventually their colon will come back around and say, okay, now I get it. Yeah, this is what I'm supposed to do. And then it gets back to normal again.
I think it's so ironic that you use the term muscle memory when we're actually losing the muscle, like we're losing all of that down there. Yet it remembers, it's selective memory. Right. Okay. So we've got those two. So keep going. Mm-hmm.
Enteral seal is your intestines. And so they sit in a sac up above that pelvic cavity. So they're up above your uterus, they're up above the bladder, they're up on top there. And they're encased in that sac, a membrane type sac, and there can be weaknesses in that sac, again, related to coughing or just pressures, and they'll break through that sac and they'll come down. They usually go over more on the rectum side, that back side there, but they can come down over the front of the uterus and bladder as well. And it's more common for an enteral seal to occur in women that have had a hysterectomy. If your uterus is gone, now you have another open space there. And the guts go, okay, we'll go down there. And so then they'll come down that direction. Women that have enteral seal are more likely to have backache, lower backache. And you may think it's a spinal thing. You may go see your chiropractor, bone cracker, whatever, and you get no relief. Well, this is a tissue-related type, organ-related type of situation. Okay. And know also that these symptoms can be very variable and intermingle with types of prolapse because women often have more than one type. Right. Okay, so then there's vaginal vault prolapse after you've had a hysterectomy. If the doctors hysterectomies are most often performed, I shouldn't say most often, but very commonly performed by gynecologists who are not adequately trained in prolapse issues. So when they do a hysterectomy and they take that uterus out, they are not tacking up the top of that vagina. I mean, the vagina is attached to something at the top. Well, if you're removing that uterus, it's not attached to it anymore. If you're not tacking the top of that vagina up, it's going to cave in on itself. So picture like a tube sock if you turn it inside out. That's what's happening with that vagina. And the top of the apex, the top of the vagina will actually come down all the way down the vaginal canal and can protrude out the vagina. All of the types of prolapse can protrude out of the vagina at the bottom. So, and with that one, I don't know that has as many physical sensation symptoms other than the visual effect of it. Right. It's painful.
Well, that's a big enough one. I would say, visual, feeling cues, but visual is pretty specific. You're going to notice if there's something popping out.
Exactly. What is that? What is that? Yes.
Okay. So we've got 4. So what's the 5th then?
Uterine prolapse. Oh my gosh. Huge. So
uterine prolapse.
The uterus can completely push all the way down and come completely outside of the vagina, your entire uterus. That's called procedentia. And with this, the symptoms are all over the board. Obviously, there's this decent sized organ that's coming out of your vaginal canal. It can cause a lot more discomfort than the other types of prolapse. Imagine, if you will, and I would think that this would be so invasive in women's lives that they would run right to their doctor and say, oh my gosh, I'm spewing organs out the bottom end.
But they don't.
I assumed this was more of a developing country issue. It's not.
It's not.
The urogynecologists that I connect with tell me all the time they do surgery for this, for uterine prolapse, all the time. And so women are just this is one that the stigma is so significant for, that they can't bring themselves to, it's how can they possibly tell anyone, that much, let's get on the table and say, what's going on down there.
So you have, I just want to make sure I understand. So there's cystocele, rectocele, uterine, vaginal vault is what I have here, mm-hmm. and the enteral seal. And you mm-hmm. said that it is common for women to have at least 2 or 3 of these kinds of prolapse.
Right.
While experiencing pelvic organ prolapse. Now, we've talked a little bit about the causes, and you've touched a little bit on the symptoms. Now we know the types, and there's varying degrees, I suppose, of severity with each type, which has to be determined by, your gynecologist or your urologist when you're working with them. But can you just briefly go over again in a comprehensive way for our listeners what the symptoms are? You've mentioned a couple of them: lower back, this kind of thing.
I'll give you all the main ones here.
Okay.
The most common, the most unsettling symptom is tissues bulging out of the vagina.
Okay.
So and that can occur with any of these types of prolapse, and how it's going to look will be different depending on which type of prolapse you're experiencing. So with the vaginal vault, it's just like little flaps of tissue because it's the top of the vagina. Whereas with the uterine, you are literally looking at your uterus, and you can see the cervix.
Right. Okay.
You're literally looking at the uterus. The other types, like with the rectal seal and the cystocele, what you're seeing, the tissue that bulges out, you're actually seeing the vaginal wall. The organ is behind that vaginal wall. So your bladder is not coming out of your vagina. It is, but it's behind that vaginal wall. So what the tissue you're seeing is actually the vaginal wall, not the bladder itself.
Okay. So we've got stuff coming out. Okay. What are some of the other symptoms?
So then there can be pain, pressure, fullness, any or all of those sensations in the vagina. Okay. You can have any of those sensations in the rectum, pressure on the backside, depending on where the positions are pushing or the organs are pushing to. Urinary incontinence is extremely common. Urine retention, the incontinence is in the earlier grades of severity. The urine retention is in the higher grades of severity, the 3s and 4s. Fecal incontinence can occur. Chronic constipation is extremely common, very, very, very common. You can have back pain, pelvic pain. You may have a lack of sexual sensation because these organs are putting pressure on nerves, which are blocking that sensation path. And of course, may be painful for you. Mm-hmm. This one I want to just dig into a tiny bit here. Picture, if you will, that you've got a bladder you're in a higher grade, your grade 3 severity. And so your bladder's not emptying properly. So your bladder's got urine in it. And you've got a rectal seal too, and that's a grade 3. And so that's pushing into the back wall of the vagina. And now you have got a penis in your vagina.
Banging. Yeah.
It can be very uncomfortable. And I've read this in studies lots of times that prolapse is not painful. And it makes me crazy because many women have got pain with prolapse. So we need to listen to patient voice. And then also one that actually was occurring with me, and I didn't put 2 and 2 together. I had no idea. The tampons will push out. You can't keep a tampon in.
Oh, yeah, sure.
If that's occurring, that is a prolapse definite sign. So those are the primary ones, the most significant ones, and they mix and match depending, again, on what type or types of prolapse you're experiencing.
Okay. I want to talk a little bit now about treatment options.
Okay.
We've talked about mesh. We know that that's an option, but that's a surgical option. Mm-hmm. Can you briefly touch on what some of the non-surgical, I suppose it depends upon the severity of the prolapse itself, but some of the non-surgical treatments that are out there?
There is a huge variety of treatments out there now. Obviously, at the baseline, we always think about Kegel exercises, but what's important for women to recognize is that if they're not doing Kegels consistently, if they're not doing them properly, they're not doing them effectively.
Listen up, ladies. She's talking about the Kegels. These are huge. I've had so many people. I mean, this is something that we've talked about since, in college, we started talking about this. So emphasize that again. Tell me a little bit about that again, and what maybe is a good, like a reps or sets, how many sets you should be doing.
You read often in articles that you're supposed to do 10 sets of 10. I think that's bull. I think it's bull. All that happens when you do 10 sets of 10 is it gets weaker and weaker, and you're not even paying attention to what you're doing. And who's got time to do 10 sets? I'm sorry. It just doesn't work that way in a real woman's life. So I encourage women to do what I do is I will do 10 sets of holds. So I'll contract in and up. I'll hold it for the count of 10. I'll release it. I'll do that 10 times. And then I'll do 10, what we call quick flicks, where you're 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And what's happening when you do that two different ways between the long hold and the short grab, there are two different types of muscle tissues in that pelvic floor muscle. And now you're targeting both of those different types of muscle tissue and strengthening them both, not just one of them. So I'll do 10, I'll do the 10 quick flicks, and then I'll do 10 more, and then that's it, I'm out. So that's actually 3 sets of 10, and I do that once a day. But I also, and this honestly, Dr. Kegel is rolling over in his grave, I swear, because he really did his homework. He built this great protocol and understanding of the value of these Kegel exercises. And it was in the 50s, it was talked about, and then it just went poof, and it went away, and it kind of disappeared from sight. So women really don't understand how to do a Kegel properly. And if you're not, sometimes they're doing what's called a Valsalva, and that's actually pushing out. When you go to your gynecologist for an exam and he tells you to push out, or like when you're having your baby, you're pushing out. The Kegel is the opposite of that. You're pulling in and up.
Okay.
And so some people say, picture it like an elevator, and the elevator is going up. So there's different techniques to try to trick your brain into how you do it. But it's consistency is important. So if you're doing them, you can do them laying down, you can do them sitting, you can do them standing. And for busy moms or women that have got their children and a full-time job, it sounds very simple. Just do your Kegels, even just do 10. But you know what? If you're doing other things at the same time, it's, you can't really focus on doing them well. So think about other activities that you do, which would be a good time to incorporate the Kegels. Like, for example, you're standing at your kitchen sink doing dishes or mixing up a cake batter, do your Kegels. You're standing in line at the grocery store, do your Kegels. So just trying to incorporate them wherever it's convenient for you, where it's something that you remember to do. I used to, for a while there, when I would grocery shop and I would take a can off the shelf, I would contract once. Okay. And so, every time you pick up your pencil, contract once, just think of what technique will work for you.
Figure out something that works for you. Right. Exactly. Now, I know there's a lot of other treatment options, but for time's sake, I just want to kind of keep moving along here. Talk to me a little bit about the surgical options and sort of the danger around that, the fear around that.
There's a multitude of different types of surgery for this, both surgical and non-surgical. The non-surgical is called native tissue repair, and they can be done with an abdominal incision, vaginally. They can be done robotically, laparoscopic incisions. So every woman's needs are different. Depends on your age. It depends on the types of prolapse. It depends on grade of severity that you have got. No woman ever has to have surgery for prolapse. It's always patient choice. That's important to recognize.
Okay.
And so with the different types, if you have that Ehlers-Danlos syndrome, where you have the weak tissue integrity, that's going to impact what type of surgery you have. If you are in your 60s and you're fully menopausal and you're not supplementing with estrogen, that's going to impact the type of surgery you have. So your lifestyle, you're very I'm a fitness geek. And so my doctor recognized that. She says, I know your type. You have to behave yourself after surgery. Yeah. And so being mindful of those that are huge into fitness, you have to take that into consideration. If you've got children, you've got to navigate the children. So all of your lifestyle, your behaviors impacts that surgical decision. And with the mesh stuff, I'm a transvaginal mesh success story. I would do it again in a heartbeat. Mesh was used for the cystal seal and the rectal seal. And the enteral seal, they just stitched with native tissue repair. And what is important to know, there's still so much fear about mesh, and there shouldn't be. The media did a horrible job of blowing up the negative side and didn't give a balanced report on what the benefits are. What's important to know is mesh is a valuable tool in the hands of a subspecialist, the top tier of your gynecologist. Right. Mesh had never been used by gynecologists, and it was, and that's why the complications happened. So what you want to look for with treatments, and they'll help you with both deciding whether you want to go non-surgical or surgical, is seek counsel with a urogynecologist. And that can be a gynecologist or a urologist who have those additional years to become a female pelvic medicine reconstructive surgeon.
Right. I think that's such an important point to make, is that we're not, the point of this conversation is not to tell people what they should or shouldn't be doing or how they should be handling the situation inside of their body, but that they have options, they have choices that they can make, and that they need to be really proactive about seeking out the right people to talk to and bring in on their team that's going to be guiding them, and they have the proper, I don't want to say necessarily credentialing, but have a lot in their rear view mirror. That's really important.
Exactly. Yeah. Get the right practitioner. And if you're not comfortable with that doctor, trust your gut, go get a second opinion, move on down the road. So, and pay attention to how many years of experience, and ask the doctor how many years of experience they have doing a particular procedure. And there's also a list of questions on APOPS website, questions to ask your doctor and mesh questions to ask your doctor. And those are both valuable tools you can download and then take that to your practitioner.
And that's also in the book. I just want to mention to everybody, because I want to encourage you to seek out this book, because Sherrie, you give so much great information in here, like what to ask, who to look for, how to prepare if you're going to go into surgery, what to prepare for after surgery. I mean, those are really important points to make as well. I want to ask you just a couple of hot seat questions. We're getting into some really interesting stuff here. I wanted to talk specifically, can you have children after you experience prolapse, or if you know you're going into, can you even have it if you have a mesh? Like, these might be dumb questions, but I just want to ask.
There are no dumb questions. You can, again, this depends on the individual woman and what was fixed and how it was fixed. They do, in general, urogynecologists gynecologists do recommend that you finish having your family before you have prolapse surgery. That's the most logical direction to go. But there are women that do have some types of prolapse repair and then have another baby.
Okay.
I don't recommend it, but it is possible. It is possible. And then you just have to take extra precautions, how you live your life to try and contain anything going south on you.
Right.
After.
One of the biggest aspects of this too, that I want to touch on, is the partner. There's not always a partner, right? Not everybody. I don't want to assume that everybody gets married or everybody has a partner, but most people do. And this will affect, you've touched on this a couple of times about the intimacy. And I'm just wondering, first of all, how do you talk to your partner? I mean, I know people know how to talk to their partners, but when it's something like in the book I was reading, some women experience coital incontinence, which basically, for those of you out there who don't know what this is, it's like you're having sex and maybe some pee comes out or poop comes out when you're having sex with your partner, which can be incredibly embarrassing and shameful. And you think you've done something wrong. Again, you've not done anything wrong. So this woman in the book, she said, this happened like once, and she was like, I'm done. I'm done with sex. That's it. I'm done. And one gal that you described in the book too, that you told her precious story, her husband actually left her. They divorced because of this issue. So we know that this can be super impactful, and sex isn't everything in a marriage. It's not even necessarily the most important aspect of a marriage, but it is an important aspect of a marriage or a partnership, right? So how do you suggest women talk to their partners about this issue?
This is one of the aspects of conversation that gets high attention from our following. We generally suggest, well, first of all, I'm organically all cards on the table. That's my personality type. It's like, get it all out there and then, sift from there. We suggest that women, it's a staging process usually. Because these conversations typically come up after the fact, after something has happened that was devastating. And especially with the urinary incontinence side of it, sometimes if it's a little bit of leakage, we don't even know. They don't even realize that they're leaking a little bit of urine during intercourse, and the guys don't realize it at all. And when it's stool, everybody notices. That's a whole different thing.
Yeah.
So coming back from that, especially for young women, is just absolutely devastating. So what we recommend that they think about doing it. Again, it's a staging process. You can't just jump right in and start talking about it. You're so devastated that typically women, when this happens, they will not, they just shut down. Initially, that's the gut reaction. They shut down. There is
it's understandable.
Yeah, and it's absolutely understandable. They're so, and the guys, it's not that huge of a deal to the guys. They're like, oh yeah, no big deal, clean up the mess, and tomorrow it's like, let's get it on again. They're over it. Whereas women will carry this internal baggage, typically for a period of time, sometimes months, before they can even talk about it. So what we suggest that they do is recognize that once they get past that hurdle of talking about it with their partner, they themselves can heal from it. And so you may have to, if you have to initiate that one-on-one conversation with your partner by saying, can we just have a drink and just sit and talk for a minute about what happened, a cup of coffee, whatever floats your boat, and sit down, make your partner sit down with you and actually let you talk about how you felt, because women feel, even though that's a bodily function, women feel dirty.
Yeah.
They feel gross and dirty. And they'll shower and shower and shower and shower after it happens, and they just can't wash that ick away. So by actually putting the conversation on the table, that's step one. And then having a face-to-face with that partner, getting that partner's reaction when you're actually looking at what that partner, because when you're engaged in the act of intimacy, you're not looking in your partner's eyes and seeing exactly what expression is on his face when he recognizes that you just pooped yourself. You're not seeing that. You're just internally realizing what just happened and totally freaking out. When you have that one-on-one conversation with your partner, you can actually look in their face, look in their eyes, see what is going on in there. And it's not usually like, oh my God, it was so gross. That's not where guys are. That's women that are doing that themselves. So realize that it wasn't devastating to him and that he wants to get back to intimacy. Men want to get back to intimacy as soon as possible. Women have to go through the stages. So the conversation is number one. And then it may be of value to women to have intimacy without the intercourse. Be in that bed together, physically holding each other, nurturing each other, and let that be your pivot point. And so it's just a staging process. And for someone, they can, go right into the whole 9 yards after they've had the conversation, and others they can't.
Right.
So the age makes a difference. It's where both of your bodies are. Like when you think about people that are in their 60s, how they're going to react to this is much different than
it's different for everybody else. What I hear you telling me in essence is, if this is happening to you, be sensitive to what's going on in your body, obviously, but don't shut down. You're not at fault.
Right.
This isn't, and I want everybody to really be hearing us when we say this. It's not your fault. It's part of your process. You're not alone. There's support out there. It's important to be proactive, even if you don't have a partner that you can talk to. Not everybody can talk to their partner. Maybe they're total jerks. I don't know. But sometimes there's just no talking to that other person for a variety of reasons. But irrespective of this, go and talk, be proactive about going and talking to your healthcare practitioner. Talk to your doctor, which leads me to one of my next questions. Obviously, APOPS is out there. You can go to Sherrie's website. There's support. There's other women who are going through the same thing. But Sherrie, let's say we're in a scenario like this, who is the first person that they should go and talk to about this? As far as an HCP is concerned, should they be asking right away for, I need to speak with a urologist? Maybe they don't necessarily know everything that's going on with their bodies, but if it has something to do with peeing or pooping or something, like usually the urologists get involved, right? So what's the first place to start out? What's best practices for that?
Well, generally, if you don't know anything about prolapse and you don't know even for sure if you have prolapse or not, your gynecologist is step one. Your PCP,
start with the
gynecologist. That you go baseline first. And then if they advise you that you have prolapse, then you go to the next step, which is your gynecologist or a fellowship trained urologist. Either one, they're equally educated and informed about that whole system. Jumping to that page right away, it's taking important self-education tools out of the process. POP is a process and start to finish. And you cannot jump from page 1 to page 97 in one appointment. So what's really important for women to understand is that they're learning about their bodies. They're learning about the condition. They're learning about how they have to adapt and change their lifestyles and their behaviors. And no woman can learn everything there is to know about prolapse in a week. You just can't. There's just too much to it. So start at the baseline and work your way up the ladder as you go.
Right.
You may get enough information to help you,
really good advice.
Figure out the path.
Is this considered by, here's the part where we get into the really dry part of the interview. Let's talk insurance. I'm just wondering, is this considered an elective cosmetic surgery, or is this something that is like it's preventative care? Do people care in our healthcare system that this is actually happening to women since it's not life? Like you can't lose your life over this. I suppose you could if they really fall out and they disconnect, but I don't know how often that happens.
And that's a rarity, and that's more in developing countries type scenario.
Okay.
So insurance-wise, these surgeries are covered. There are some that they're considered aesthetic procedures, and they shouldn't be. So when you're talking about something that is going to treat incontinence, that is not actually a surgical. It's considered a surgical procedure, but it's like introducing laser heat or radiofrequency heat treatments into the vaginal canal, which can temporarily, but radically help treat incontinence. those aren't covered. Those are considered elective cosmetic procedures, that's crazy. They group them with if you have a vaginal facelift. They're not the same. It's not the same,
Right.
But
right.
the actual procedures for prolapse itself, no matter what type it is, those are considered all surgeries that should be considered covered by insurances. So obviously everyone's got different deductibles and copays and all that kind of stuff.
Right.
But in general, they are covered by insurance.
How much does mesh, if you were going to do a surgical implant of mesh, do you know how much that costs in general? Like,
that's really variable. Every surgery related to prolapse is higher on the coastlines, east and west coast, than it is in the middle part of the country.
Okay.
And when they were allowing transvaginal mesh, which is now disallowed because, we went through all the mesh stuff in the 2011 timeframe, got that all sorted out and made sure that only the subspecialists were utilizing transvaginal mesh. It wasn't handled appropriately overseas, and then all these complications were happening over in England. So that rebooted it here. So because of that, in the States here, they have now disallowed mesh being inserted vaginally. And so we're talking about going in more frequently abdominal incision, which is a more expensive procedure. And robotically, I believe, is a more expensive procedure. So it depends on which doctor you're seeing. It depends on what all procedures that they're doing. I would guess that this is it would range anywhere between $15,000 and $30,000 for the surgery before, and that's insurance taking care of, the majority of that, obviously.
Wowza, yeah.
So then you're left with, whatever your portion is to have to pay after they do, and then they cover whatever they cover. So
I just want to kind of getting to the end of our conversation here, but I want to just throw out some statistics that Sherrie notes in her book that I think everybody needs to pay attention to. 13 to 15% of women suffer from some level of incontinence. This is just in the United States, right?
Mm-hmm.
These are just, okay.
This is the problem with finding statistics. It's so variable by study. It's so frustrating. You can find,
13 to 57%. That's a huge range.
Yeah.
But even 13% of the population, that's significant for women to be. I don't know anyone who doesn't, it's like, a little bit of stress incontinence here and there. I don't know. It's like how people are, it's all the perspective that you're looking at it from. But it is significant.
Yes. And you have to bring into that picture also that a lot of women, if they're questioned, won't admit to incontinence. So what is the real number? Is it really on the low end, that low number, or is it higher than that right out of the chute because women aren't admitting to it? So as a perfect example of that, a prolapse itself, you can find, I use 50% prevalence. You're seeing 50% prevalence more and more in studies all the time. Some say 50% in Paris women who've had babies, and some say 50% in women across the board, which is the number that I use. But you can find a study that says 3% prevalence and 97% prevalence.
But I'm guessing that a lot of this questioning is because women don't talk about it. Because there's so much shame around it. And okay. So there's more than 300,000 surgeries for pelvic organ prolapse annually in the US.
Yes.
We know childbearing and menopause are the leading causes of POP, which you discussed earlier, but multiple additional causes increase the factor for women of all ages, ladies. This can happen to a woman as early as 30, 25 in some cases, depending upon the childbearing. 21% of patients who have POP have some loss of bowel control. 30% of women with urinary leakage suffer from loss of bowel control. 30% of women will undergo multiple surgeries for pelvic floor disorders. This is startling. The number of women who will undergo surgery for POP is predicted to increase by 46% by 2050. This is a global issue, though. I think you said at the top something like you understand, or based on current statistics and what you know about this, that about 50% of women globally are impacted by this in some way, shape, or form.
Exactly. And if that number is not accurate, it's going to be higher, not lower.
Right. We're painting with some pretty broad brushstrokes here, but based on what we know.
And it's important to note that until all women are screened for POP during routine pelvic examinations, we won't have accurate data.
Okay, so what's the answer to that? Is it a petition? Is it?
It's a matter of and it has to start at the Medicare. Everything starts at the Medicare level. finding those right Congress people who've experienced prolapse and will admit that they've experienced prolapse to get on board with this and to build that initiative to shift the protocol, shift the curriculum that's provided to the gynecologic, well, anyone that's providing pelvic examinations, address those shortfalls that are currently in existence.
Right.
That's a big slice of pie.
I think that's so interesting you say who are willing to admit, because I suppose that could be perceived as like a weakness they needed. It's like you're moving, ladies, you're moving so fast. You are so strong. Your body can't even just keep up with you.
Mm-hmm.
You're using all that muscle. Sherrie, I could ask you like 1,000 more questions about this. I just think this is a fascinating subject. I'm so grateful that you've taken the time to talk to me about this today. I know that we have only touched the tip of the iceberg. I am so well aware of that. But I just wanted to say thank you. If you're interested in learning more about pelvic organ prolapse, APOPS, and the work that Sherrie's doing, support group, Sherrie's book coming out in September and more, her website, again, is pelvic organ prolapse support.org. Sherrie, it's been an honor and a pleasure to have you on the podcast today. I know our listeners learned something new, and I wish you well as you continue this invaluable mission.
Well, thank you so much, Mary. And I have to applaud your effort to get the word out there to women. It's priceless to what we're trying to do. The need for this information to be in the hands of all women is critical. It's critical. So it's voices like yours that help make the magic happen. Thank you for the opportunity to join you today.
Well, thanks for saying that. I really appreciate that. I do care passionately about this. So folks, I want to thank you for checking out this important discussion today. Until next time, keep chasing your true north.